program. This is the first, our inaugural Zoom meeting of IPS Pharmacotherapy Subcommittee, and I welcome you all. And we are so fortunate and blessed to have the great speaker, brilliant speaker, top academician and private practitioner, Dr. Malay Dave from Mumbai. And chairperson is another two great academician, my chairperson, Dr. Manu Arora, and Dr. Nishant Goel from CIP Ranchi. And we are so fortunate and blessed to have SARC Psychiatric Federation President, Dr. Gautam Saha amongst us. Dr. N. Raju Sir, President of Indian Psychiatric Society. Dr. Vinay Kumar Sir, Vice President of Indian Psychiatric Society. Our Honorable General Secretary, Dr. Arvind Brahma Sir. Dr. Alim Siddiqui, Treasurer. And Honorable Editor, Dr. O.P. Singh Sir. So I welcome you all the office bearers of IPS. Dr. N. Raju Sir, are you present there? If you can say a brief few words about. Sir, are you there?
I don't think he is there.
Okay, fine, yeah. Dr. Vinay Kumar Sir is traveling now, so he has sent his message, video message. Ethan, if you can share the message. Why is this not coming, Ethan?
President of Indian Psychiatric Society, Dr. N. Raju, and other office bearers. Chairperson of Specialty Section on Psychopharmacology, Dr. Manu Arora. Convener, Dr. Tirthankar. Advisor, Dr. Rajesh Thume. And EC Coordinator, Dr. Kaushik Chatterjee Sahab. At the outset, I must apologize that I'm traveling and I'm not present with all of you during this very important webinar. Friends, psychiatry has interfaced with almost everything under the sun, including sun. But the system of body, which is most important, which is the host, medium, and target, is neuroscience. We can't understand psychiatry without understanding neuroscience. The revolution in psychopharmacology became possible only after we started understanding brain, nerves, and physiology and functioning and pathology, everything much better. NBN classification has almost replaced the older one. We all know how much tailing kind of classification this is. Once you understand this, once you know this, you understand the core functioning of all the drugs. I congratulate the specialty section for choosing such a brilliant topic and such a brilliant speaker like Dr. Malay Dave. Our chairpersons, Dr. Nishant Goel and chairperson.
Now, if we can have a brief word from Dr. Aravinda Brahma, Honorable General Secretaries. Aravinda da.
Thank you, Tirthankar. Thanks for the invitation. This is the first program of IPS psychotherapy, pharmacotherapy subcommittee today, and the committee consisted of 4 most dynamic persons: Dr. Rajesh Dhume as advisor, Dr. Manu, my dear brother, as chairperson, Dr. Tirthankar, my another brother from Bengal, as convener, and Dr. Kaushik Chatterjee as EC coordinator. And for the first program, you have chosen a very important topic, the I think this is very important in the present day context, especially for us, for the clinicians. And Dr. Malay Dave, I think he is the best person to speak on this particular topic. So I don't take much time because we all are waiting here to hear from our speakers. So thanks once again to IPS Pharmacotherapy Subcommittee. Thank you and best wishes for today's program. Thank you, Tirthankar.
Thank you. Now, can we have some few brief comments from Alim Bhai?
Thank you, Dr. Tirthankar. It is a pleasure being invited here. I think we all know Dr. Malay Dave. He is a very good friend, one of the best speakers that we have, most knowledgeable person. My regards to Dr. Gautam Saha sir, SARC President, all the office bearers of Indian Psychiatric Society, Dr. Rajesh Dhume sir, the advisor, Dr. Manu Arora and Dr. Nishant Goyal, who are my dear seniors, and my love to you, Tirthankar Bhai. I wish all the best to the program, all the success. Thank you so much.
Thank you. Now, I would request my dearest elder brother, Opida, are you there? Our president,
I am very much there.
Yes, Opida. Then Opida, if you can say a few words about our subcommittee and all these activities.
First thing, I must congratulate and thank the Pharmacological Committee for inviting me. We know the advisor is Rajesh Dhume, Chairman Manu Arora, and the most dynamic convener, Dr. Tirthankar, and EC coordinator, Dr. Kaushik Chatterjee. And this is a galaxy of presenters like Malay Dave. He needs no introduction. Nishant is there. And of course, you is moderating. So I think pharmacology is our bread and butter. Whatever we say, we earn and live by that. So having a skill in prescribing and learning pharmacology is the utmost important thing. So this seminar will go a long way. Again, my best wishes and congratulations to you all.
Read the Bible.
And finally, I request my dearest elder brother, Honorable Dr. Gautam Saha, President, SARC Psychiatric Federation. Gautam Da, if you can say a few words about this subcommittee, your final comments.
Thank you.
Yeah.
Thank you, Tirtho. Dr. Tirthankar Dasgupta, my dear brother. It is really fantastic program. In fact, at the outset, I must thanks to all the IPS office bearers and all this committee members, starting from the advisor, Dr. Rajesh Dhume, one of the most active always. Last year, he was in TCA, Transactional Analysis Group. Now, also, we have Dr. Manu Arora, one of the most active members of Indian Psychiatric Society. And I don't want to say more about my dear brother, Dr. Tirtho. He's always fantastic, always very sincere. And this group is really doing well. In fact, I'm telling you, starting from the choosing of the subject, as all of you know that the neuroscience and psychopharmacology, whenever we learn neuroscience, we are restricted to the different lobes of the brain. Now there are different 300 nodes of the brain, connection of the brain, different connectums. So it is somehow changes, and pharmacology also somehow changes according to them. And definitely it will be better. Future is coming in front of us. And who is the best speaker in this connection? Definitely, except none other than that is Dr. Malay Dave. We have a chairperson like Dr. Nishant Goyal, Dr. Manu Arora, and moderator Dr. Tirthankar Dasgupta. I'm really proud, all of you. I'm sure, I'm confident this will be a great session. And who are not attending this program, they will definitely miss something. And I'm sure that this is fantastic. Being in the USA also, I am attending the APA, but still I am here to listen this, because this is really great. It will be a great show and great academic twist. Thank you so much. Thank you all of you.
Thank you, Dada. Now I request our most dynamic advisor, we received a lot of advice from him and a blessing. Our advisor, Dr. Rajesh Dhume sir. Rajesh sir, are you there? Rajesh sir, I don't think he's there. Anyway, he has sent his blessing to us, and also our EC coordinator, Dr. Kaushik Chatterjee, also sent his good wishes to us. Now, I would hand over my mic to two of the dynamic chairpersons, and before that, Hiten, can you please start the slideshow so that I can introduce two chairpersons. Chairpersons, Hiten, not Malay sirs. Next two. Yeah. My chairperson, Dr. Manu Arora, is the head of the Department of Government Medical College, Jammu and Jammu Kashmir. His area of interest is addiction psychiatry, psychopharmacology. He has 40 number of publications. He received R.B. Davis Gold Medal Award, BPSS Award, and Samuel Gershon Award. And next chairperson is dynamic Dr. Nishant Goel. Hiten, can you please show the slide?
It's in a meeting. I'll just join. I'll just join.
Next one, Hiten. Any problem, Hiten?
I think Dr. Nishant needs no introduction.
Yeah, that's true.
Known to everybody.
Introduction still for the
A dear friend and an avid researcher. Yes.
Yes. Is the in charge of Center for Child and Adolescent Psychiatry, FMRI Center for Cognitive Neurosciences, and in charge in academics. Is the program coordinator of mental health and psychosocial support during pandemic for CIP Ranchi. Is the program coordinator of CIP Digital Academy, joint secretary, founder member of Neuromodulation Society. Is the editor of our Eastern Journal of Psychiatry, IPS East. In the review editor of Frontiers in Psychiatry, Child and Adolescent Psychiatry. His areas of interest and specialization is child and adolescent psychiatry, non-invasive brain stimulation, public mental health. He has 90 plus number of publications and 20 plus awards and fellowships. Over to two dynamic chairpersons, Dr. Manu Arora and Dr. Nishant Goel. Now I hand over my mic to them. Thank you.
Thank you. Dr. Nishant, please, if you can take over, and I'll just introduce the speaker before I go for my presentation.
So I think we are already running a bit late, so I'll request Dr. Manu to please, we can start the proceedings, we can have our comments and question answer later on. So let's start with introducing Dr. Malay Dave. So Dr. Manu, if you can please do the honors. Thank you.
Yes, Dr. Malay Dave. So he's an MD, DPM and a DNB working in private practice for about last 25 years. He was the Honorable President for Bombay Psychiatric Society 2016-17. He is also a project coordinator for Autism Dynamic Interventions 2008 to 17. So that is long 9 years. He's author and co-author in a number of articles and book chapters, and his areas of interest is neuroscience, which is very aptly as a topic of today's discussion. So I will hand over the mic to Dr. Nishant for further proceedings, please.
Thank you, Dr. Manu, for introducing our speaker. So, Dr. Malay, thank you first of all, sincere thanks to the IPS and the psychopharmacology subcommittee of IPS for having me tonight. I know it's a very busy Saturday for all of us. A lot of programs going on, but as all of us have mentioned, that this is a very, very important topic, and Dr. Gautam Da has made it an international, event, attending it from the US. So definitely, as we all know, that we have come a long way from chlorpromazine or maybe reserpine to now the NBN classification. I'm sure Dr. Malay will be talking about it in his deliberation. But still, I would, try to put forth the point which we might discuss if we get time. That I think few years back, British Journal of Psychiatry came up with an editorial. The title was "Psychopharmacology: Is there an end in the tunnel?" So we all know that when it comes to newer molecules, we are at loss. Not many new molecules are coming up in the field of psychiatry. So definitely neurosciences might be an interesting vista or an interesting way where we can reanalyze, reclassify, or maybe find out new molecules which might help our patients who are suffering from various mental disorders. So with these words, I request Dr. Malay Dave to please start his deliberation. Over to you, Dr. Dave. Thank you.
Thank you, chairpersons, for the kind words and setting the tone for today's topic. A big thanks to the IPS Psychopharmacology Subcommittee for inviting me for this inaugural talk. I'll start this. I'll share my screen. Just a moment. Okay, is my screen visible?
Yes.
Yeah, and am I audible?
Absolutely. Please go ahead,
Yeah,
sir.
yeah. Okay. Fine. So I would. There's just a small request from the chairpersons. I would not like to be very lengthy in my talk. So maybe when it is around 30 minutes or so, just give me a hands up or shout something or just shut down my screen or something. So that it's a warning for me not to overshoot. And I'll begin. Now, basically, the topic that we are going to talk about today is neuroscience-based psychopharmacology. It's an overview. So I would like to compare this topic to an editorial of any journal, which is basically a summary of what is going to come in the following pages in terms of the various articles, various research, and something like that. So it's going to touch upon some topics. It's not going to be a very in-depth psychopharmacology talk, because well, if I speak everything now, what will happen to the other speakers and the other topics later on? So it's an overview, and this overview I have kind of designed around what thoughts went on in my head when Dr. Tirthankar kind of discussed with me that well, I need to speak for this speak on this topic. So what shall we cover? We'll cover in brief all these few points: history of psychopharmacology, what's in the name, that is basic nomenclatures and classifications, what's the nature of psychiatric illnesses, placebo responses, and personalized medicine. For me, when we talk of psychopharmacology, it is kind of quite an interchangeable concept with regards to neuroscience. So if there is no neuroscience, there is no psychopharmacology. And there is no psychopharmacological agent which doesn't have some kind of a connection with neuroscience. So these things are kind of one and the same for me. So let's get on. Right. So if you look at this topic, if you look at this chart, what it shows is the timeline where we have kind of experimented with various agents which have got psychotropic properties. Pre-1900, alcohol and opiates. Early 20th century, paraldehyde, chloraldehyde, bromates, barbiturates, and so on and so forth. Now, what is important is not the left side, but the right side. If you look at the right side, there are two rectangles here. One is in light orange and one is in light green. The orange one says serendipity and the green one says rational design. Now, what it means is that most of the drugs that we use from day one in psychiatry, benzodiazepine, tricyclic antidepressants, methylphenidate, chlorpromazine, haloperidol, clozapine, and lithium, most of the very effective psychotropic agents, most effective psychopharmacology has been discovered by serendipity, means by pleasant chance or by accident. It is only after these drugs were found to have certain effects on certain conditions did we start really looking at the mechanism of actions of these molecules. When we looked at the mechanism of these molecules, we understood maybe these are the mechanisms that underlie the disorder and so on. So till about mid 20th century, so let's say 1950s, 1960s, by the time all these molecules were kind of available to us for use, it was all serendipity. None of the molecules were designed specifically in a lab taking certain substrates into account. For example, if you look at chlorpromazine, there are 4 or 5 people who could be attributed with developing the molecule as a psychotropic agent. In fact, it was used in war times to calm down patients. And that is where it clicked in somebody's head that this can be used for psychosis also. It's only in the later half and towards the end of the 20th century when we started becoming more specific. So more precisely late 1970s and 80s. So we had SSRIs, SNRIs, mixed amphetamine salts, SDS, the second generation anti-psychotics, and so on and so forth. And now in the 21st century, we are dealing with more designed, so to say, rationally designed molecules like gabapentinoids, ketamine, esketamine. We are looking now at what was again serendipity here. Now we are looking at the drugs like LSD, psilocybin, and things like that. So neuroscience was kind of an accidental entity here. But here, let's say in the last 30, 40 years or so, it is becoming a part, it's becoming a tool in understanding how agents work and how we need to design them. Okay. Now, I remember that when I started learning pharmacology in my second MBBS, that is about 30 or more years back, the only classification that was available was minor versus major tranquilizers. Minors would be the ones where they would say that you use it for anxiety or less severe problems, and major tranquilizers for more severe problems.
Sorry to interrupt. Dimple Galaxy 1, can you please mute? Ethan, if you can assist to mute, except the speaker, Dr. Malay Dave, sir. Not possible from my end.
Okay, can I proceed?
Muted, sir.
Yeah, can I proceed?
Yes, sir.
Yeah, am I audible?
Yes, sir.
Okay, fine. Yeah, so the earliest classification was this major versus minor. It's a very old classification, and the only thing that we hear about it is from patients who will come and tell us, doctor, any medicine that you give is going to basically put my patient to sleep or me to sleep. What is different? So it becomes difficult for us to tell them that all medications are not the same. All of them are not, in quotes, tranquilizers, and they have got different effects. So one of the stigma that arises because that arises when we prescribe medication or any kind of psychopharmacological agent to our patient is because of this thing. Everybody is trained to use these terms, and these have been there, and only in the last few editions of any pharmacologic textbook have they been replaced by better names. The next group of names that we started using after we started using more psychopharmacology is antipsychotics, antidepressants, anxiolytics, mood stabilizers. Now the problem with these names is again rigid categorization. So if I'm using antipsychotics, and if I, let's say, give a low dose antipsychotic as an augmentation agent in somebody who is resistant depressed, the person is going to say, why are you giving me, I'm not a psychotic patient, why are you giving me an antipsychotic? If I'm going to use low dose risperidone for behavior problems, let's say in autistic children, the mother is going to ask me why my child is not mad, that kind of thing. Antidepressants are no longer by antidepressant, the term by itself doesn't actually specify any category like SSRI or SNRI. But if you look at the utility of these drugs, it is much more than just unipolar major depression. There are a wide variety of uses. So we have got this NBN classification and a proposed model. We'll come to that. And then there are these three other things which we need to look at. So now, this lack of meaningful connection between the nomenclature of psychotropic drugs and the underlying neuroscience. So if we look at this, point number 1 and 2, right? This has been a long-standing concern within the neuropsychopharmacological community. Yes, because one, it increases stigma. Second, it doesn't sound very good if for a depressed patient, I am using a drug which has got the name depression in it. So kind of it is jarring. Second, what it actually does, it's kind of a mystery. So together with representatives from ACNP, CINP, Asian CNP, and IUPHR, the NBN task force was formed to address this concern. This is verbatim, which I have taken from their website, which is the ECNP of Europe. The NBN is a publication, it's a digital application. Okay. So it is updated yearly. And I don't know how many of us use it on a daily basis. The principles are to move from a disease-based classification. So that was point number 2 in my slide, 2 slides back, to a pharmacologically driven classification. And in order to shift from symptoms to mechanisms. Okay. So it is not that I don't get sleep because I am depressed, but I would say that maybe there is a serotonergic disturbance in depression. This corrects it, and hence you get better sleep. To open the gate to contemporary neuroscience insights and to incorporate new research findings. Now, as I said, that initial so many years of psychopharmacology was serendipity. We found out that certain drugs have got certain effects that led to the development of, so to say, what are these mechanisms which would lead to improvements. Now, whether the improvements in this kind of a thing or a disruption in these mechanisms is the basic cause for a psychiatric disorder to happen, right? So the mutual understanding of how a drug works and on the substrate that it works could help us to find more about psychiatric disorders. Okay, to replace older nomenclatures and to provide an important teaching tool that reflects the depth and richness of neuroscience fabrics. Okay, so what is this NBN, neuroscience-based nomenclature? Remember, we are talking here about neuroscience-based nomenclature. The topic for today is neuroscience-based psychopharmacology, which is slightly more because this is just about names. And that's why the second topic that we are talking about is what's in a name. Right. So what does it have? It has got 2 websites. One is NBN second edition revise, and one is NBN child and adolescent. So there are 2 things. One is general psychiatry, psychopharmacology for general psychiatry, and the second one is psychopharmacology for child and adolescent psychiatry. There are 2 apps. So the same things are available in apps. Now these apps are available both for iPhone and Android, free to download. I have them on my phone since they have been published. I have all the versions. I mean, it updates like any other app, and a number of books. So the books are again printed version of this. Okay. So how does it look? So this is the NBN3 official app. Okay. So this is the face page. So when you click on the app, this is what comes up. And then it says who are all the partners in developing the NBA and nomenclature. So this is the page after the first page, face page. So here we can type any molecule. This is the 3rd version. So this NBN was first available to us about 5 or 6 years back. So it will be around 2015-16. So when we type in any name, generic name, not a brand name, any molecule name, we will get information on pharmacology, mode of action, approved indication, efficacy, side effects, older terminology, pregnancy. Okay. right? And this is on the, when you click on these three lines, you get something. How does it work? So it's basically a kind of an instruction. So 10 pharmacological domains, 9 modes of action, comments, and things like that. Okay, so I typed in haloperidol because I don't know why I typed haloperidol, because maybe I tend to use a lot of haloperidol still for various indications apart from psychosis. So here we get all these kinds of things. It's a dopamine antagonist. Then what are the indications where it is used? All of them. Improvement in psychotic symptoms, main effect, what are the side effects, and practical notes on some drug interactions. The substrate, the haloperidol as a substrate for various CYP450 enzyme subsystems. Dosing, what was the older term, antipsychotic, and some neurobiology. Neurobiology would basically mean pharmacology and mode of action, neurotransmitter effects in humans, physiological preclinical human, basic brain circuits preclinical, and brain circuits human. Now, and the last one is of course pregnancy. What is the pregnancy risk? Now, the good thing is that when we have it on our mobile phones or laptops or tabs, okay, even it's a very simple kind of an app. It is very easy to navigate, okay, and the thing is that you get all this very quickly. This is very essential, very basic, very core information that we need at the tips of our fingers. We may not remember all of this. I don't remember all of this in details, but it's, it's at any time it's easy to brush. This are the 3 or 4 pages which will give us everything that we need to know regarding that drug in our clinics when we use it for patients. Sometimes patients will ask a lot of things about side effects. I read this on Google, this, and I read on this and stuff like that. So we may not really get onto Google at all times. We may have not very good networks, like Tirthankar had a problem, but because this is a very efficient small app, we can get this thing very quickly. Okay. Now, this is what it gives us. If we look at the neurobiology, so that is basic neuroscience part, most of the things after the first 2, they do not have any entries. So that means we do not have much information which is preclinical. Okay, preclinical would mean things that went into developing that molecule, or kind of effects that were seen in animal models, which may be different from the effects that is seen in a human being as a patient. Other physiological effects in a human being worthy of note. Brain circuits preclinical, that is research, and brain circuits in humans. Now, why this may not be there is because at the time when haloperidol was kind of discovered, it was serendipity. Nobody designed it in a lab for use as an antipsychotic. So all these kinds of studies in details and the information that we could have got may not be available. Okay. So for many of these older molecules, this neurobiology section seems kind of empty. Okay. Now, the other thing that we have is NB and CNA. This CNA is here. It's kind of written in a kind of a vertical manner. But again, this child and adolescent section also has the same things: name, pharmacology, mode of actions, approved indications, efficacy and side effects, older terminology. Again, the same thing, similar to that, except that this is now in the second version, that is the third version. This will also get updated once we have got more information. So the commonest drug I put in a child and adolescent is methylphenidate. So where does it act? What kind of an action? What are the effects, positive effects, side effects, practical notes? Okay. Dosing, what was it called previously as a stimulant? Okay. And basic neurobiological stuff, preclinical effects, human effects, physiological, preclinical. Okay. Something we could get on brain circuits, that is preclinical, what happened in animal models, and brain circuits in human beings based on fMRI studies. So methylphenidate, if we look at that first chart, first figure that I showed you is towards the middle of last century. So probably some studies have been done before this was clinically available for use in ADHD. So we have got some information. Okay. So now the question is that we have this with us, right? We have this, it has been updated, NBN is 3rd edition, this is 2nd edition. How many of us are actually using it on a day-to-day basis? That is question 1A. The main question is how many of us have it on our mobile phones or on tabs? Because this is very easy. At a glance, very easy. We can get all the basic stuff. Even if we do not remember the full spelling of haloperidol, if we put it hello, we'll still get it. The search part is so easy. So this is the NBN classification. Now, what people felt was that again, this could become a bit too complicated. So because we have to remember, we look at haloperidol, it's D2 antagonist. If you look at methylphenidate, it is both dopaminergic and norepinephrinergic. So maybe it is a little bit complicated just to kind of remember it that way. So there has been another attempt by Seifert and Shermer. This is a paper that was published in 2020, that is about 2 years back. And again, they tried to give us a similar approach to naming the drugs. Okay. So in the NBN, the drugs were named according to their predominant mode of action. It would be an SSRI, SNRI, and things like that. So why these people wanted to have a slightly different version? These are not the terms that are used in NBN. These are slightly different. So again, they felt that if you should not use these terms which are antidepressant, anti-epileptic, because, well, one is they become very categorical. Second thing is people would find this kind of words and categories stigmatizing, because the disease itself is there in that word. So we do not want to use disease, because the same thing will happen. Why are you giving me an antipsychotic if I'm depressed? You're giving me another label, and so on and so forth. So this naming thing is becoming really problematic. So these people, two people, they thought, let us give them some different kind of a name which has nothing to do with antidepressant. Okay. It also gives their main mechanism, but in a slightly different manner. They must, of course, have gone through NBN and all, but this is slightly different. So antidepressants, they called norepinephrine serotonin enhancer, NE or 5-HT enhancer. So they didn't even call it an inhibitor, SSRI, no negative of any sort. So inhibition is also not used. It is an enhancer. Anti-epileptic drugs are called as neuronal inhibitors with pleiotropic effects. Neuronal inhibition means they kind of stabilize the nerve membrane, and pleiotropic effects are, apart from the anti-epileptic effects, we use it for a number of things, whether it is behavior problems, violence, mood stabilization, whatever. Antipsychotic drugs are called as multiple G protein coupled receptor antagonists. So instead of dopaminergic antagonist, okay, we call them, this is mostly atypical, so SDAs. Okay, so these are all the dopamine receptors or serotonin receptors are basically G protein coupled. So these are just not receptors, just open up the channel. They are attached to the second messenger systems, and so I've got a kind of cascade of events that happen when the drugs bind to those receptors. So antipsychotics are called as multiple G protein coupled receptor antagonists. Okay. Typical antagonists are D2R, so D2 receptor specific MGPCR, and atypical antipsychotics are protein coupled, multiple protein coupled GPCR. So we know they act on receptors apart from dopamine. And mood stabilizers are again MGPR antagonists and with this NIP. So that way. So again, in that classification, the antidepressants, older ones, we have got these enhancers, which are again alpha 2 adrenergic receptor antagonists like metazapine, non-specific serotonergic receptor inhibitors like amitriptyline or clomipramine, SSRIs, SNRIs, and things like that. So what they are trying to do is that more importantly, rather than the drug action, they are trying to get away and strongly give us alternative names for the categories that we are using. So getting back to this, we don't call drugs antidepressants or SSRI or SNRIs because it's everything is clubbed under this enhancement which leads to a clinical effect. Anti-epileptic drugs, no, we will not call them by any name, but we'll call them by their action, which is a gross action. And then we have got more under this NIP: calcium channel blockers, sodium channel blockers, glutamate release inhibitors, alkali metal ions, and so on and so forth. Right? Older antipsychotics, haloperidol would be D2 receptor MGPCR, and this ones would be PMGPCRs. Okay, so this is how there has been attempt to be more specific about the drug and its action, to not use categorical terms, because we know that psychopharmacological agents have a wide variety of use apart from their predominant use. And number three, we do not use, according to many people, stigmatizing words in the category of the drug itself. So this is one attempt, both NBN and this one. Now, when we again go back to this, so we have finished this 1, 2, 3. Now, what has happened till here is that we have been kind of moving around, juggling around with the proper names. We are trying to understand the mechanism. We are trying to understand the mechanism of how it is useful for various conditions apart from only psychosis or depression. But what has also happened with this three, rather not with this three, but along with this, is that we have been focusing more and more on what happens at a neurotransmitter level. So it is all dopamine, it is all serotonin, it is all monoamine, other monoamines, it is glutamate. And that is where we have kind of come to a obstacle or a block where we are not moving ahead. We seem to have exhausted the avenues of looking at the same neurotransmitters again and again and all over again. So we have got molecules which are slightly different in their receptor binding profile when it comes to neurotransmitters. So instead of D2 and 5-HT2, we have got D2, D3 and things like that. So what happens is the effect more or less remains the same. There might be some marginal benefit, but we still face problems on a daily basis when patients do not show adequate response, patients do not show a prolonged response, patients are not very well stabilized, and things like that. So we have to now look at, and people have now begun to look at this, the last three: the second messenger systems and signaling systems, epigenetic mechanisms of psychopharmacological agents, and genetic mechanisms. And why is this important? So before going into a brief about these points 4, 5, and 6, let us see the time frame in which the drugs work. If we give anything to a patient, we always tell them that the drug will start acting. It is going to take a few weeks, maybe 4 to 6 weeks, for a stable effect to be seen, after which we'll keep you on a maintenance dose, then we'll slowly reduce and see and stuff like that. And why do we say such things? Is it just because we are taught this way, or is it our experience when we see drugs in actions? But we also need to understand these drugs actually work that way. If the drugs are, let's say, acting at a specific receptor on a specific neurotransmitter, then that neurotransmitter effect will have an immediate effect on the symptoms. It is going to have some intermediate effect on some symptoms, and it's going to have a delayed effect on some symptoms. And that is what is more interesting than just the drug acting on a specific neurotransmitter receptor. So when a drug combines to a receptor, it also sets into motion activation or inhibition of second messenger systems and activation and inhibition of signaling systems. these systems, when they work or not work, depending on activation or inhibition, they kind of take on the action of the drug on a longer time frame. That is where that effect seems to be kind of, initially there is an up and down, the stabilization has not reached. And that is what is going to take some time, because these systems are getting affected. And then our drugs, I'll show you some research on that, also seem to be having an effect on epigenesis and probably on genetics of an individual also, because of which, even on a longer period of time, many patients do well and may not have a relapse again. So coming to point number 4. So after NBA and after this classification, about 4 or 5 years back, we came up with endoxifen, which is a totally different kind of a drug, because it doesn't work on our classic understanding of neurotransmitters. It is a PKC inhibitor, phosphokinase C inhibitor. Phosphokinase C is a kind of an enzyme which is at higher levels in the neurons of a patient who has got mania. And because of its overactivity, it kind of has got effects on multiple things which cause and which prolong the manic episode. So if you have got a PKC inhibitor, then it can take care of manic symptoms. Now, this is an action which is completely different from a dopamine antagonism or an anti-glutamate mechanism and things like that. Okay. So we'll not get into the details of that, because we have heard many speakers speak on PKC signaling in mania, then bipolar disorder. It's one kind of a piece in a jigsaw puzzle of mania. And if this PKC is inhibited, then this whole jigsaw is stabilized. And that is where the effect of endoxifen comes into play, right? So basically, PKC and this DG keta, they are kind of in balance. And in bipolar, both of them are impaired, and it also impairs GPCR signaling, that is G protein coupled receptor signaling. That is what causes mania. This is the diagram that is what is meant to say. So one drug that we have definitely, which we are using, which is not, how would you put that drug vis-a-vis the neurotransmitter that we have learned is a different thing. This is an additional mechanism. This is a newer mechanism, and this seems to be working, whether it is bipolar disorder or anything where the cell is getting hyperactivated. When we look at mania, we think of a patient who is talking more, who is spending more, who is overconfident, who is sleeping less, who is grandiose. But at the brain cell level, it means that the cell is hyperactive. It is working more. The connectivity of the cell is working more. So that whole system needs to calm down. And this, by working at the PKC inhibitor endoxifen, by working at a key point in this whole intricate scheme of things, seems to stabilize or quieten down the neurons. Now, we also know, and these are studies, and if you look at the study years, 2003, 4, so about 15, 20 years back, since then, this kind of basic studies in animal models have shown us that the existing molecules also, especially if you see this whole third column, antipsychotics, is about olanzapine, clozapine, and haloperidol. These three drugs, antipsychotics, the older term, D2 antagonist, the NBN nomenclature, these molecules have got not only effects on dopaminergic system, but on CAMP and PKA. PKA is kind of a similar enzyme system as PKC, phosphokinase A, GSK-AKT, GSK-WNT. So these are signaling systems apart from neurotransmitters that we commonly know of, that are getting targeted by these molecules. So this also forces us makes us think hard whether it is only the dopaminergic effect or rather the anti-dopaminergic effect of these molecules which is bringing about a change in these patients that we treat them with, or these are the other mechanisms which are also important, though these studies are there in basic preclinical kind of, not preclinical because these drugs have always been available and these have been tried afterwards, but in basic animal models from the basic neuroscience point of view. MAPK. So this 3 or 4 second messenger or third messenger systems, CAMP, PK, GSK, AKT, GSK, WNT, and MAPK are all systems apart from dopamine, which are targeted by molecules that we commonly use. The same thing happens with mood stabilizers or NIPs, neuronal inhibitors with pleiotropic effects. So lithium, valproate, carbamazepine, lamotrigine, again the similar ones. So what this means is that this kind of drugs, they have got a stabilizing effect on the functioning of the neurons, apart from their basic action of whatever it is. And antidepressants as well. Fluoxetine, imipramine, venlafaxine. So that was the fourth one. The drugs, apart from their classical neurotransmitters effects that we look at, have also got additional effects on second messenger system. And we have got a new drug for clinical use, for daily use, for all of us, that is endoxifen, which is a PKC inhibitor. That is a signaling, a specific signaling intracellular acting drug. At a still basic level, our drugs, this this chart is taken from a book which is called as Epigenetics in Psychiatry. So all the chapters are on about epigenesis and how it affects or has a role in psychiatry, whether it is development of the disorder, development, brain development itself, and things like that. So this is a chart which has on the left the drugs that have been studied, and the various columns are the different kinds of epigenetic changes that happen, that are known with regards to these molecules. So if you look at antidepressants, again, if you look at imipramine, it inhibits histone acetylation. It has an effect on histone acetylation. It has an effect on histone demethylation. It is an effect on DNA methylation. So all these are epigenetic changes which are associated with brain development, which may not be okay, and then which can lead to the development of psychiatric disorders as we know them. So all our drugs have got these kind of effects at various epigenetic sites within our cells, which means that, and of course, all these drugs are known, these are not new, but this is another way of looking at it, because these drugs actually over a period of time can bring about epigenetic changes, actually can reverse epigenetic changes to an extent which have already been there. So valproic acid, histone acetylation, it has got an effect on histone acetylation, right? On histone demethylation and DNA methylation. So this is another arena, this is another area of looking at and developing drugs which has got epigenetic effects. If we need any drug to have a good effect, a lasting effect, and an effect that will cover a lot of areas, then we need to have drugs which act like this, because when it acts on the basic DNA, the epigenetic effects on DNA, then it can really bring about a lot of change and some more. Okay. That brings us to the next thing is with the help of neuroscience, how we understand psychiatric illness, because the previous section was on how we look at drugs, what do drugs, how we have understood psychopharmacological agents in terms of their modes of action at different levels, how how they teach us something more about the pathophysiology of the psychiatric illness itself. And that brings us to the question of what are psychiatric illnesses? What basically DSM-5, TR or ICD-11, which is now widely used, is just a collection of symptoms. They are not going to tell us what has caused the disease. They are not going to tell us how symptoms were caused or how things developed, right? So that way, it's just a collection of symptoms. So it's a syndromal diagnosis, and it is a cross-cutting. It's basically a cross-sectional diagnosis. So if I'm seeing a patient right now, it's maybe around 8:30, 8:45, and I'm seeing the patient in my clinic, this is what my impression is at this time. What has happened 5 years back, how it has contributed to the illness now, what's going to happen 5 years down the lane, I have no idea. I can make some prediction, but that is not the illness. When we look at neurobiology or when we look at neurosciences, the models and the explanations that we have kind of give us more understanding of what an illness is, how it progresses, what are the various things that happen at it as an illness progresses, and what can be done. Why is it important is, so how is an illness caused? So basically, this is a kind of a experimental approach, but basically an individual's genome has to have certain vulnerabilities in terms of some variants. These variants would have some epigenetic marks, some RNA effects. This leads to the development of certain neurocognitive traits, imaging phenotypes, other traits, behavioral traits, metabolic traits. With a vulnerable genome, the things arising out of a vulnerable genome and an environment that actually can set things into motion, we finally have a disease. So it is not gene to a disease, or it's not environment to a disease. There is a lot of things happening in between. So when we look at the genetics and epigenetics, this is something which we now know better. So this is basically the epigenetic map of a bipolar disorder brain. Very simple, 4 or 5 areas are there: prefrontal cortex, frontal cortex, anterior cingulate cortex, cerebellum, and deep dorsolateral PFC. These are the areas where this kind of epigenetic changes have been found in patients who have got bipolar disorder. Fine. Now, many of this we have kind of looked into because our drugs have got certain effects. So we know of demethylation, histone modification, and so on and so forth, microRNAs, right? So we have now begun to understand that illnesses are not just symptoms, as I mentioned before, but there are a lot of things happening. We can study some of these, and this is how it probably happens. So even before the first mood episode, if you look at this first mood episode here, there are so many things that have happened. So inherited factors like genetic factors, familial aggregation, paternal age, delayed development, certain milestones, issues with milestones and cognitive abilities, brain alterations right from the word go, heterotopias, certain subtle anomalies, epigenetic changes, early programming of HPA axis and inflammatory processes, early environmental insults. So before the first episode, everything has to be in place. And then once the process starts, then there will be what we see: relapses, recurrence. The same thing with schizophrenia, genetic variants in combination with environmental risk factors, so molecular changes, cellular changes, circuit changes, and traits, finally leading to a disease, to a symptomatic presentation or a phenotypic presentation of disease. Once a disease like psychosis, schizophrenia is there, it is not a static outcome. It keeps on changing. So when we probably see some patient who has first episode psychosis here, there are already so many things that have happened similar to what we looked at in a patient who has bipolar disorder. Negative symptoms seem to be the base on which this positive symptoms keep on fluctuating. A lot of psychosocial issues could be adding to the whole syndrome of an illness. At a neurobiological level, altered synaptic formation, altered synaptic pruning, disrupted balances, gray matter loss, dopamine dysfunction, everything. And it doesn't change very easily because these things are actually set. So what we are going to see and what we say when our patient gets better is maybe these things are a little bit less, but these things that are happening at the basic, at the background maybe remains, and that's why relapses, recurrences, poor responses, and so on and so forth. Any disorder, again, like autism, will have the same kind of a thing: epigenetics, mutations, genetic susceptibility, environment, sex-linked modifiers, because we are seeing more autism in males than in females. Okay. Another area which is very important and upcoming now in the last few years is the role of microglia. With neurotransmission, that is the first 3 points, we focus mainly on the neuron. But what we also need to focus on when it comes to the other 3, epigenesis, we look at second messenger and signaling systems, epigenetics, is basically how the microglia are involved in the process of pathogenesis of an illness. This is one way of looking at it. This is a paper from 2017 which says that when there is psychosocial stress and already existing disorder, psychosis, depression, or bipolar, psychosocial stress can cause peripheral inflammation, basically HP activation and pro-inflammatory changes. This happens in the microglia in the brain, and this subset which shows inflammatory changes. So this is the whole psychosis group, and in that group, a group of patients who show microglial activation and inflammatory changes have poorer outcomes with standard treatment. So maybe we need to think of anti-inflammatory treatment targeting microglial activation. This is one new substrate that people are thinking about. So in addition to clozapine, still not responding, treatment resistant, severe symptoms, suicidal behavior, what do we do? Further adding an antipsychotic may not help. Further adding some D2 blocker may not help. So we need to think a little bit differently. This is what neurobiology teaches us. Now, again, when we look at bipolar disorder, there are so many areas where different kinds of inflammatory changes have been found, predominantly in hippocampus and amygdala, again, frontal cortex, anterior cingulate cortex. What is also important for us to understand, and what neurobiology teaches us, neuroscience teaches us, is that psychiatric disorders do not happen in isolation. Means the changes that are happening when it comes to inflammation or epigenetic changes, these changes are seen in all cells of the body and not only the neurons and the glia. So there will be primary mediators, neuroendocrine and metabolic stress, okay, oxidative stress, cellular dysfunction. And since cellular dysfunction is there, then each and every system get affected. And the common things we see are other non-communicable diseases. In fact, this last thing is very important because one, this means that there is a gradual progression of any illness over time. And secondly, psychiatric disorders, patients with psychiatric disorders have got a reduced lifespan compared to patients who do not have, and they have only, let's say, other non-communicable diseases. So these psychiatric disorders that we deal with daily have got systemic outcomes, reduction in the lifespan, faster aging, and so on. That brings us to something that we face daily, and that is treatment resistance. In fact, it is quite common than it is actually acknowledged. And we look at treatment resistance in a very clinical sort of a way. This is where we really need to apply our neurosciences, the different models that we have now, and look at this phenomenon of treatment resistance. We look at remission recovery, we look at symptom recovery. Then we are always confused about operational definitions, whether I use 2 molecules of different categories or 3 molecules of 2 categories for some time, and so on and so forth, whether we should have used a stimulation procedure or an ECT or something before calling it resistant. This is what we are always in a dilemma about. And so this is how we actually look at treatment resistance. So there is a onset of the disease, there is a period of untreated, there is a period when there is no treatment, then the patient comes to me, then I treat the patient for a certain period of time. this is actually a research model, but this is actually how we go when we are in a clinic. We treat a patient, patients don't drop out, but they don't respond. Then we go get into a certain other drug and something, and then it goes on and on. So at a certain point in time, after 2 or 3 drugs, now we have to worry what is going to happen. This is our standard way of looking at resistance. This is how we have different criteria for resistance, clinical resistance. When we look at other things, whether the patient is compliant, adherent to treatment, and availability, and all those kinds of things. But what we actually need to look at is and understand is that this treatment response is also dependent on everything that we talked about. It is not only I have given him a certain molecule and he has not responded well and I substituted. In fact, treatment resistance starts way before that. By just giving one drug after the other, we are just prolonging the time, because treatment resistance depends on the same things as the illness. What are we talking in or understanding with regards to this patient in terms of his genetic makeup, his epigenetic marks, the various kind of circuit dysfunction, or the various kind of messenger systems and second messenger system dysfunction. What is the illness is going to lead to treatment resistance or response. It's the same factors. The only thing is that for some patients who respond fast, maybe their systems are working a little bit differently than those who are going to be treatment resistant in the long run. And we have no other way of looking at it apart from giving a trial of one drug after the other. And that is where neuroscience tells us that we should have better means. We should try and look at more number of parameters apart from history and all. Of course, it is easier said and done. Many of these things are still in an experimental phase. It's not available for me right from use tomorrow, even if I'm talking about it today. Right? Another thing that is always going to be complicating the whole picture is the placebo response. The placebo response is pretty high when we treat patients across diagnoses and across modalities. It is basically suggestion, cues, social cues, treatment cues, expectations, emotions. All these form the base of a placebo response. And again, placebo response, we have now begun to understand, has got certain neurological correlates. This is another very interesting part of neuroscience, which actually contributes a lot to our day-to-day treatments. Many of the times, patients will come and say, "Doctor, you give me a medicine. I came to you 4 days back and I'm perfectly fine." I don't think any medicine works that way. So whether it is a placebo effect, and we need to be able to differentiate and use that placebo effect to the good of the patient. The placebo effect, also like any medication effect, is not uniform over time. These are the areas for pain, expectancy, motivation, avoidance, schema. Many of these areas are basically focused, located on the prefrontal cortex, dorsal and medial orbital prefrontal cortex, and anterior cingulate cortex. So these regions basically are also part of mood, also part of our cognition. So whatever disturbances are happening in these areas can also have a kind of a placebo response to our treatments. Right? Right. Coming to the last part, which is just a few slides, so not much there. What we have now looked at, so just in a few lines. First, we looked at the history of how we have discovered psychopharmacological agents, how we have kind of named them, how we are now looking at substrates, target substrates apart from our classical neurotransmitters, because with neurotransmitters we have drawn a kind of a, we are running into a wall. We need to have other approaches. How these drugs that we know of, in addition to their neurotransmitter effects, have got an effect on second messenger systems, on epigenetics, maybe genetic effects also. Everything is in progress right now. how we look at things, how we look at the basic psychiatric disorders. They are not just diagnoses, or they're just not collection of symptoms. What all things go into making a psychiatric illness? Why treatment resistance itself is a part and parcel of the psychiatric disease that a person, it's not a separate something new. How placebo is an important component in any treatment. With psychiatric disorders, the placebo response is a higher percentage compared to treatments for other disorders of other systems. Now, when we look at all these things, parameters, apart only from seeing patients and giving them medical treatment or whatever treatment, we need to understand that it's not this. Even if we see 10 patients of psychosis, each one psychosis is not going to be the same. Each one's prescription that I give is not going to be the same, and everyone is not going to respond in a similar way. So there is something called as precision medicine. It's an emerging approach for treatment and prevention that takes into account each person's variability in genes, environment, and lifestyle. There was an initiative launched in 2015 by the then president of US. Medicine has always had a personalized approach. Means whenever anybody comes to us, we take a good history, we try and give the best possible treatment. We kind of weigh the benefits and advantages, disadvantages, the effects, side effects, everything we try to take into account. So we are used to a personalized approach, but it is not precise because there are many other things that are needed apart from history taking, clinical examination, and investigation. So this is basically a complete picture of what is precision psychiatry. Now, for a patient, we look at some of these things: clinical history, demographics, some investigations here and there, some environment, some ECG, or for us EEG, some testing, cognitive testing. But there are so many other areas which we need to make them more utilizable, because they are also a huge source of information. So we need to have an epigenomic profile, that is the epigenetics changes that are there in that individual. The transcriptomic profile, that is all the different kinds of RNAs that are there. The genomics, the metabolomics, basic understanding of the metabolic pathways in that person. And that is important now, because when we treat patients, let's say with olanzapine, we see a lot of weight gain, but that weight gain doesn't happen in every patient, and the weight gain is not the same in patients who have gained weight. So what happens vis-a-vis this drug to the metabolism of that individual depends on that individual's metabolic profile. Proteomics, okay, health records, mobile data, okay, imaging data, and so on and so forth. So we need to integrate. We need to first gather a lot of data, systematically use this data to predict something for this patient, whether the prediction will be how their disorder or disease is going to turn out, what kind of treatment is going to work best. Because if you have this kind of something happening in reality, it is not in real this thing at the moment, but if we have this kind of a thing, because all these things are possible only because of the advances that neuroscience is making. It is actually taking into account each and everything with regards to a particular individual. Only thing is we need to get a good kind of data. We need to be able to integrate the data with a lot of other things and have good prediction models. So all these things are being worked upon. And when we have this, just a few slides back when I talked about two things. First thing was treatment resistance. I will not really need to wait for 2 or 3 failed drug trials to label somebody as refractory to treatment or resistant to treatment or non-responsive. Maybe if I have a good profile and a good prediction from something like this, all the data available from all the artificial intelligence or machine learning that I have at my disposal, I might be able to start that one molecule right from day one, which has a promising kind of an effect for that person. I will not wait for 4 trials for 6 months and this and that, go to another psychiatrist, third opinion, fourth opinion, and things like that. So I will avoid wasting a lot of time in selecting a molecule. So resistance part is less. Second thing is, when I have this kind of a data, I will also be able to understand or get a peek into whether this person is going to be, what kind of a placebo response this individual is going to show us. And that is how I can also modulate some other things. So when there are these confounding things, there are too many things that we do not know of, all these kinds of things under the heading of precision psychiatry can make it easier for us to identify these things and address these things right at the beginning, rather than get into a treatment, get confused, change treatment if when not needed, and do things which may not really be result oriented. So with precision medicine, there are lots and lots of papers on precision medicine in psychiatry, but I just chose 2 because they are clinically relevant. Precision psychiatry applications with pharmacogenomics. So we know of pharmacogenetics, where we could send a saliva sample and then they will assess the CYP450 enzyme systems mostly and tell us that this drug is going to be moderately effective and so on and so forth. I don't know how many of us have actually done this exercise in some of our willing patients, because even the testing part is costly. It's not it cannot be done routinely, and the results that come are also equally confusing to interpret. So that is pharmacogenetics. Here we are talking of pharmacogenomics. The difference between genetics and genomics is that pharmacogenetics is going to focus on certain aspects of the metabolism and drug handling. So commonly available ones are CYP450 enzyme system, whereas pharmacogenomics is the sum total of all the genes that are going to be involved in all aspects of metabolism, not only the P450 enzyme subsystems. So, well, different kinds of statistical models have been applied, and basically this is this tells us how accurate this is. So it is promising, but it is not really going to be available so soon. And another one is using polygenic scores and clinical data for bipolar disorder patient stratification and lithium prediction. So even for lithium is one molecule where we know quite a bit about how the molecule acts, and because of the way we have understood lithium, we have also understood what happens in the basic pathophysiology of bipolar disorders. And we also know it's a simple molecule, it's not a complicated compound. So we also understood about what are the genes that can affect the handling of lithium in the body. So we have got huge data, and of course a lot number of people working on this data. And the best and then there's various models. Since this is not about precision medicine per se, I'm not getting into the details of how they go about it, but something like this is important for us to make a good assessment or predict how an individual is going to respond to lithium. So having said that, I'll end my talk. Thank you so much for being patient and hearing me out. I hand over the proceedings to the chairpersons and questions and answers if there are any. Thank you so much.
Thank you, Dr. Dave, for making a very, very difficult topic so interesting and so simplified. Being an overview, definitely the listeners and the viewers today would have definitely understood the nuances of using neuroscience, particularly in understanding the various ways how we understand the mechanism of action of various available drugs, the newer mechanisms you talked about, particularly, the signaling mechanisms. Then finally ending your presentation with something, a particular topic which is very close to me, my understanding and my heart is basically using, precision medicine or precision psychiatry. Basically, you're right. Precision psychiatry is nothing but creating huge amount of data and trying to create biosignatures for an individual person with a particular issue. So thank you once again, for such a lucid presentation. And yeah, so I think we can take some time if the organizers, allow. So I'll request Dr. Thankar to please take over the proceedings of asking some questions or taking some questions which are already there in the chat box, if there are any questions in the chat box. So over to you, Dr. Tirthankar, so that you can ask questions to Dr. Malay Dave. Over to you, Dr. Tirthankar. Thank you.
Thank you, Nishant bhai. Now the forum is open for the questions, and I received few of the questions in the chat box. Meanwhile, first question from Nishant Boss himself: how neuroscience is or going to help in future in terms of reducing time for medications to act or start working, particularly in acute conditions, for example, ketamine?
Actually, my chairperson has asked 2-3 questions, so I'll start with that neuroscience of in terms of reducing time for medications. So see, ketamine again is one thing which acts quickly, but it doesn't do so in all our patients. So basically, if you are really able to tailor, kind of the use of ketamine. In fact, some patients, when we give them ketamine, they end up having more psychosis-like symptoms immediately, and then once that thing settles down, they have kind of panic attacks for a few days. Maybe patient selection is not okay. So the ideal thing would be how we are able to select that patient properly for ketamine. Now, again, it will come down to there's a nice book on ketamine and the genetics of response to ketamine and things like that. So without going into detail, let me tell you that when it comes to more newer development in neuroscience, there are a lot of studies which focus on the genetic and epigenetic mechanisms which will affect a response to a certain drug or a group of drugs. So whether it is antipsychotics, we should not use the word antipsychotics, but 25 years of practice is old school, so it's not going to go away so easily. So the traditional drugs that we use, each of them has got a response. Basically, a drug is going to act on the response. Ketamine is an NMDA antagonist. So we need to basically we should be able to figure out how responsive or how different this individual's NMDA is compared to mine. Let's say both of us are depressed. So if we have that kind of a pharmacogenomic understanding, that is drug handling. But if there is an imaging, let's say there's a genetic imaging or a molecular imaging that way, maybe that would help us better. Having said that, the best way to bring to use ketamine quick is to look at that patient who probably only has unipolar depression, who has that classical suicidal thoughts, who doesn't seem to have psychotic symptoms, who is not having a bipolar personality, borderline personality disorder. As we know, if we are able to keep this out, then we are almost guaranteed that the response is going to be quick. The problem with ketamine, we also know, is that after a few successful sessions, some people may just not respond. So the effect kind of wears out. So that was one thing. And the second thing he has asked on what are my thoughts on development of vaccines like dementia and substance use disorders. I think when it comes to dementia, we don't have vaccines, but we definitely have monoclonal antibodies to the abnormal proteins that are produced. Most of the studies I don't think have had clinically significant improvement as endpoints. So I think we'll need to kind of get back to the drawing board and see. Again, the problem is that these disorders, now whether it is dementia or substance use disorders, the vaccine is useful. Let's say to give an analogy of COVID, the vaccine will be useful only if it works on a certain substrate in each and every variant of the virus. If in that substrate there is some change in the structure of the protein, then the response is not great. Either the vaccine is ineffective or it partly acts, increasing the chance for a relapse or a reinfection or something like that. So for us, when we look at disorders, they are different from infections in the sense that we have to really pinpoint that one substrate which is there in all kinds of dementias, even in Alzheimer's dementia. Even when we look at addiction, which part of the brain do we target, which neurotransmitter system, which inflammatory molecule, pro or whatever, which marker. So unless we have that, we will have these things. Monoclonal antibody is a good thing. Another thing that we have is this CGRP antagonist for migraine. They're a kind of antibodies, again, not vaccines, but antibodies, like a monoclonal antibody. So we have, but unless and until we have got one specific target which is there across these disorders, it may not work. I think that is what I've understood from whatever literature is available and what kind of studies have been there and why we are not really successful with that.
Next question, again from Nishant Bose, is what are the bridging trajectories between RDoC and NBN classification?
So the only bridge is that we are looking at neurotransmitters and some mechanism of action, whereas RDoC is pretty comprehensive in terms of it takes into account the networks that are involved and the different traits that are underlying that are a function of these things. So again, novelty seeking, all those things, which NBN doesn't touch. NBN is specific to the molecules that we use, mostly neurotransmitters, whereas RDoC is everything that we can put into that metric. So many things that we can. So a small kind of overlap here.
So do you think, sir, in future, RDoC would help us to evolve and evolve the NBN system into much a higher version? So currently NBN is limited to the outside cell.
So it's like this. Forget RDoC, but people who are studying drugs, people who are studying the etiopathogenesis of illnesses, if we get good data, robust data, many of the charts that I use showed basic animal models and data, which is okay. But now whether this is completely we can corroborate with what is happening in human beings is a totally different thing. So once we have that kind of data, then it should be easy to incorporate in our diagnostic system, that is RDoC, and for people who are developing drugs or studying the different effects of drugs. One thing that I should mention here is that in the last 2 years, in the COVID pandemic, we have heard so much about our drugs, the drugs that we use being repurposed for COVID, especially fluoxamine. And at that time, we never focused on the serotonin reuptake inhibition of fluoxamine. We talked of something else, how it is going to affect the virus and viral multiplication and things like that.
I think there's a recent editorial also which has come, I think, if I remember.
So things like this have actually forced us to wake up and look at our drugs in a completely different light. But that also means that we also have to look for similar mechanisms underlying our illnesses, whether something like this is there. Okay.
Yeah.
So yeah, let's see. So if we have good research, then it's easy for us to incorporate, whether it's in our pharmacological classifications and nomenclature, as well as in understanding the illness and diagnosing the illness.
I completely agree with you, Dr. Malay, because we Indians, particularly in our country with more than like 1.3, like such huge population, if you can think of, we have this responsibility of creating, developing, or having some robust data.
Yes,
which can
you are
definitely help others as well as,
yes, yes.
to create or understand mechanisms in a better way, or maybe in a more precise way. We can, pinpoint the various mechanisms of action of various medications. Yeah, absolutely. Dr. Tirthankar, there are a few more questions if you can take
Yeah,
the last.
yeah. I found one interesting question from Vandana Gupta. Sir, role of anti-inflammatory drugs to target neuroinflammation.
Anti-inflammatory drugs to target neuroinflammation is, well, first of all, it is not a routine thing. Because when I gave that diagram of the model of those three things, psychosis, depression, and bipolar, and there is a subset of those patients who have got neuroinflammation as a predominant thing, we need to first understand what are the markers that we are going to look for in these people. And secondly, what is the role of anti-inflammatory agents, whether I'm going to give steroids. It is really not very clear unless the markers are robust. We can start with C-reactive, highly specific CRP levels and see, but I would not really suggest that with the current knowledge we use anti-inflammatory drugs right, left, and center as of now, because neuroinflammation is something slightly different from the systemic inflammation that we see, and maybe the same things may not apply to treating psychiatric disorders routinely in our clinic. So
One more important thing is that most of the drugs, the biggest hurdle is like whether they do cross blood-brain barrier or not.
Yes, that is one thing. And second thing, which I would like to point out to Dr. Gupta, is that we need to now also look at, and of course, I would just make a request to Dr. Das Gupta is, we have this new category, it's actually new, of something called as autoimmune psychosis.
Yeah.
Right? Which is a whole new game of an identifiable psychosis, like what psychosis we see in our clinics, but a very clearly identifiable neuroinflammation as the core, and how it responds partly or not at all to our standard treatments, and what kind of anti-inflammatory strategies we need to put in place. It's a very interesting thing. The concept has been developed in the last 10 years or so. It's not that old, but we are all the more wiser because this is actually one category which is our, so to say, category, but with a lot of understanding on the basic neuroinflammatory processes that are going on.
Yeah, another interesting question from Dr. Namita Nazir: how to choose an appropriate agent for psychodermatological disorder, especially delusion of parasitosis. A trial of risperidone and duloxetine failed for a 54-year-old female with 20 years history of crawling, biting, burning sensation all over the body, now seeking treatment due to severe exacerbation. No physical or neurological problems.
So
any particular neurobiological factor to be considered?
See, neurobiologically, how we would look at it, whether it is a delusion, as a delusion, and delusion also, we now look at it as it's when we talk in terms of networks, it's a slightly different thing. So when we're looking at involvement of neural the networks, different networks, maybe you will need to look at see, clinically, when I started my practice for such patients, I used to use a drug called as pimozide, which was good. It had got good effect. It's a typical D2 antagonist, an older generation of antagonist, a longer acting molecule. So that used to be good. But currently, when there is this kind of a preoccupation with that almost to a delusional level, you should also think of using a good dose of an SSRI along with a low dose of a D2 blocker. That is probably where it would work. So again, these two categories of drugs that Dr. Namita has written about, you can use different molecules, but with a different kind of a profile. Duloxetine and SNRI, I would prefer an SSRI predominantly, something in this regard. So you can change. But yes, neurobiologically, if you need to look at it, then we're not getting into it, because it is all a matter of how information is processed by various networks, finally leading to a somatic delusion-like experience for this patient. So,
Next question came from Dr. Priyam. For a male patient in his 40s with paranoid schizophrenia for 20 years, who took medications only for a month or 2, 5, 6 years back in the entire duration of illness, what should be the antipsychotic of choice? Again,
yeah,
choice.
I mean, for all practical purposes, this patient is an untreated patient, because there's hardly any treatment that has been received. So it's if you look at the clinical profile, it is basically something like a very long duration of untreated psychosis. So it would depend on what is the symptom profile for this patient. What are you targeting? Now, if this patient has so many years of psychosis, and if you look at the chart that I had shown about how the disease progresses, maybe this is the time when the patient is going to have mostly negative symptoms, some fluctuating positive symptoms, so to say. So you would probably need something like, maybe if I was there, I would really think about starting clozapine right from day one for this patient. And maybe for the negative symptoms and SSRI, something like that, a combination like that, see how it works. So rather than making any guesses, I would say that you really look at what is the symptom profile right now, and start treating accordingly. The important thing here is to start him and keep him on treatment. I mean, for a duration of untreated psychosis so long, we just don't know how that response has happened. I mean, what is the response going to be? So you can start with anything, but if you really look at it from that neuroscience point of view, this patient is, according to me, a good candidate for clozapine. So we are not very comfortable with starting clozapine right from day one, but this patient has so many years of psychosis which is untreated. So that kind of as the disease progresses, psychosis, we know that psychosis itself is neurotoxic. So neural degeneration, the degenerative processes are already on. So at the moment, what is the symptoms? It might be paranoid schizophrenia, but what are the symptoms that will determine what you would probably use in this patient?
Next question. Do we think certain psychotropic drugs will supersede other medications due to precision medicine? Also, do we think non-psychiatric drugs will be more in the horizon due to more systemic approach of our field?
So what we need to understand is that once we understand, once we look at a patient comprehensively, the patient's profile, the entire profile of the patient is going to tell us what is going to be the best drug. So yes, if let's say haloperidol has been my favorite drug throughout this presentation, if I present this thing again after 20 years, it might not be so. Things might have changed. We might have got more information about certain disorders, about patients. So maybe it will change. Second thing is, do we think non-psychiatric drugs will be? Yes, there would be, because we need to understand and be very clear about psychiatric illnesses, that these psychiatric illnesses are systemic illnesses also. Most chronic psychiatric illnesses have got, the patients with these illnesses have got a reduced lifespan by 15 to 20 years. And they have got, as the disease progresses, their systems also kind of, other systems also kind of get involved in other non-communicable diseases. We have drugs like olanzapine, which bring about, in a vulnerable individual, weight gain and the attendant metabolic syndrome. So right now also, without so much of knowledge about precision medicines, many of us are using, along with olanzapine, something like some drugs which will stabilize the metabolism. So we have to be open to these things. We are as psychiatrists, we think only of delusions, hallucinations. We need to relook. That's why I got in this section of how do we look at psychiatric symptoms, psychiatric illnesses. These are part of systemic illnesses with predominant symptoms, which are anxiety, depression symptoms, psychosis, but with far-reaching consequences in other systems also.
Yeah. And if you consider the molecular mechanism and all this thing of the
Yes.
drugs, then the
because if we look at inflammation, it is at the core of many illnesses, including psychiatric illnesses in different parts of the body,
diabetes also,
different systems.
Okay, I think we need to close this session now. No further question we got. So Nishan bhai, can we,
Yes, once again, thank you so much, Dr. Malay, for such insightful comments and answers to all the queries. So with this, I would like to again thank you very much, and thank you, Dr. Tirthankar, for giving me this opportunity to be part of today's session. So over to you to close the session. Thank you.
Thank you. Thank you all. Thank you all the delegates, and thank you, Dr. Malay Dave, for such a brilliant, excellent presentation and such a difficult topic. You made it a very simple and lucid one. And thank you all. So we need to close this session now. Okay. Good night, everyone.
Good night. Bye.
Good night.